Um, we have again the pleasure of having Dr. Pawha again here with us again from the Department of Radiology, one of our new radiologists. He's been giving us, if you guys have recalled, he's been giving us a few lectures throughout the academic year. And this is his final lecture in the series, and it'll be mostly about tumor infection. So we're very happy to have Dr. Pawha back again to share his expertise with us.
Thank you.
Okay, great. Thanks a lot, Andrew, for inviting me again. It's always great to come up here. So this is the third in a series of 3 talks. And, if I'll just kind of remind you guys, we originally talked about things like hydrocephalus and herniation. Those are the kind of easiest things to glean very quickly in the acute setting on a head CT. And we also talked about parenchymal abnormalities that are dense or bright, which is predominantly hemorrhage. When things are hypodense or dark on CT, it becomes a little bit more challenging to tease out what the cause of it is. And so that's what the second and third lecture kind of focused on. Last time we talked mostly about ischemic stroke, and this time we're going to talk about tumor and infection. So, should I just call this talk "Get an MRI"? Probably I should have, but there's really a lot of information you can glean from CT. Of course, CT is just so easy and quick that most patients will get a CT in the acute setting, and there's a lot you can tell. And the important thing is to first and foremost differentiate from stroke. Make sure you're not looking at stroke, in which case, obviously clinically sometimes it's very clear that that's the case, but sometimes the picture is a little bit cloudy, and the imaging does help quite a bit, even just an initial CT. And then, once you kind of decide we're not dealing with a stroke, there's a lot we can kind of learn and say about tumor and infection from a CT prior to getting an MRI as well. And of course, there are some patients that can't get an MRI and can't get contrast, especially in recent years. There's much more awareness about NSF, nephrogenic systemic fibrosis, and so some patients don't get contrast for that reason now, which never used to be the case. So don't worry, we're not going to really go through all of these tumors here. This is kind of the point of this is just that, brain tumors is a huge topic, and clearly, each one of these categories could be a whole lecture in itself. But I think that what's really within the scope here and to talk to you guys about is just to kind of look at a basic approach for lesions that are not stroke or hemorrhage. When we see an abnormality in the parenchyma, how do we kind of approach it and kind of make some sense out of it? So the first thing I think is just to decide the location. And the very basics of location is it a brain lesion or is it a lesion outside the brain? And it may seem simple, but sometimes it's difficult to tell between the two. If you have a peripheral lesion, was it a dural-based mass or an extra-axial mass of some other sort, or is it actually a brain mass that's kind of on the periphery and protruding out a bit? And then that leads to a different differential diagnosis in each compartment. Is there edema associated with the lesion? Parenchymal intraaxial lesions are more likely to have edema. Extra-axial lesions may or may not have edema, but if there is edema associated with the lesion, how do we characterize it? And we'll talk again. We'll remind ourselves about the 2 classic types of edema we see in neuroradiology: cytotoxic and vasogenic. And mainly, again, this is to exclude that we're not looking at a stroke. Most tumors in infection will have vasogenic edema as opposed to cytotoxic, which is seen with stroke. And then, of course, characterize the secondary findings: herniation, hydrocephalus, things that require urgent attention. And then beyond that, we can get to some characterization if there is, beyond just the parenchymal edema, if there's a focal lesion, we can look at the density of the lesion on non-contrast imaging and the enhancement characteristics of it to arrive at a better differential. So in this case, is this lesion intraaxial or extra-axial? What do we think? You guys can just shout out what you think.
Can you explain what it means?
To be, yeah, so intraaxial means a lesion arising from the brain parenchyma versus a lesion arising outside the brain, either from left meninges or dura or something outside. So do you think this is coming from outside or inside the brain? No, because this is a little higher up, so we're kind of beyond that level. But so I heard some people say extra-axial, some people say intra-axial. So it's clearly not always that obvious here. Here, this is cortex here, and so the lesion is really inseparable from the cortex. So could this be a lesion kind of arising from and expanding the cortex? It's very uncommon, actually. So typically what we do is we find the gray-white junction, and if it's buckled away from the lesion, then it tells us that it's an extra-axial lesion. It's a lesion coming from outside the brain. It's actually very uncommon to have something, if it is basically inseparable from the cortex, to be really arising from the cortex and expanding the cortex without involving the white matter. So, just as a very easy thing, if you can identify the gray-white matter junction, and if it's buckled away from the mass, then that tells us it's probably an extra-axial lesion. And here, this is after contrast. We see this was very homogeneously enhancing, which is typical for meningioma. And you can see it's kind of based along the falx. This is the falx cerebri. And you can see there's a tail of enhancement here. That's also classic. It's called a dural tail. It's very classically associated talked about with meningioma, but it's actually not specific for meningioma. It really just tells us that it's a dural-based mass. It's rising from the dura most likely. So this is an extra-axial lesion, and here you can kind of better see the gray-white matter differentiation. All of this denser stuff is gray matter cortex, and the darker stuff centrally is white matter. So this is a gray-white matter junction, and it's pushed away from the mass. So that's what tells us that this is an extra-axial mass. And the most common extra-axial mass is meningioma by far. So here, do you think this is extra-axial or intra-axial? So this is also an extra-axial mass, and here we do see the gray-white matter junction here pushed away from the mass, but we also see another useful sign, which is called the cleft sign. And you see this little bit of curvilinear fluid-like density, and that's essentially you're visualizing a little bit of the subarachnoid space that's between the mass and the gray matter. So if you see a little bit of CSF cleft, that also tells you you're dealing with an extra-axial mass. So these things can kind of help us. Then we know right away that okay, this is an extra-axial mass. There's a certain differential, which we'll get to in a minute. And we wouldn't necessarily be thinking about something like a glioma or a primary CNS lymphoma. So extra-axial masses, by far and away the most common is meningioma, and then there's some features that we can see on CT that can help us kind of really cinch the diagnosis as well, like calcification of the lesion itself may or may not be present, but if it's there, it definitely is more suggestive, and hyperostosis of the bone adjacent to it. It's a very vascular hyperemic lesion, so it causes kind of bony overproduction of the bone right adjacent to it, and I'll show you an example of that. But if you see an extra-axial mass like this, just enough to say that okay, this is going to be probably either a meningioma, a dural met, or much less commonly lymphoma leukemia based on the dura. That gives you already a very good picture of what this could possibly be. So remember, this is a dural tail that we described before. It's not specific for meningioma, but it does help you know that this is a dural-based mass. And in some specific locations, there are other things in the differential, like in the IAC region, you're going to think about schwannomas versus meningioma. So that's a classic differential for the internal auditory canal or CP angle cistern. In the sellar region, it's going to be pituitary adenoma versus meningioma, and you're going to try to distinguish those two. And then you can also have pineal region tumors as well as an extra-axial mass. So here, this is a non-contrast CT. So it looks like there's something kind of very bright and heterogeneous here. Is this a big parenchymal hemorrhage? Well, it's a possibility based on just this. But if we give contrast, we see that it enhances diffusely, it's homogeneous. So this was a meningioma, a large meningioma, and we're actually looking at the calcification within the lesion itself. on non-contrast studies. So that was also the fact that it's calcified helps us kind of think already that it's a meningioma versus another dural-based tumor. And then the fact that it enhances diffusely tells us for sure that it's a mass, it's a tumor, it's not a hemorrhage, even though it's looking bright on the non-con like hemorrhage might. And this is an MRI, just kind of better showing the diffusely enhancing mass. So this is the case we were looking at just before. So we have this extra-axial mass with a little bit of a cleft sign here, buckling of the gray-white, classic findings of an extra-axial mass. So this is the bone window. So, what do we think this is most likely to be? So meningioma is definitely the most common, but as I mentioned before, it usually has hyperostosis, so it has bony thickening adjacent to it. And this actually has erosion of the bone. You can see the bone looks ratty, it's kind of eaten away. So this is much less common to happen with a meningioma. And so we'd be worried about something like a dural metastasis, and that's what this was. This is an example of a typical meningioma. So this one happens to have calcification within the lesion, which is classic, but it also has this hyperostosis. And if you see this hyperostosis in conjunction with a lesion, you can pretty much count on it being a meningioma. It's pretty specific for meningioma. Okay, so what do we think about this mass? This is kind of peripheral in the brain also. Is this intraaxial within the brain, or could this possibly be a lesion from outside kind of pushing into the brain or invaginating the brain? Intraaxial, I heard someone say. So yeah, this is an intraaxial lesion. Occasionally you can get fooled and something can look intraaxial when it kind of pushes in and invaginates into the brain. But if you look at the gray-white junction here, so it's not buckled away from the lesion. It's actually surrounded by the lesion, and the gyri overlying are kind of expanded. And there's a large amount of edema surrounding this round lesion. So even on a non-contrast CT here, we can see the mass itself. Sometimes that's not always the case, where you actually need contrast to see the lesion, but sometimes you can see it even without contrast. So this is a lesion, intraaxial lesion, kind of peripheral in location, has a lot of surrounding edema, and this is typical vasogenic edema where it spares the cortex. You nicely see the differentiation between gray and white matter. So when you see edema associated with a lesion, and as I mentioned, intraaxial lesions are much more likely to have edema than extraaxial lesions like a meningioma, although meningiomas can invade the brain and can cause edema within the brain. However, that edema will be usually eccentric to the lesion rather than surrounding the lesion. So it's important when you see parenchymal edema, again, to try to characterize it as either vasogenic or cytotoxic. So which do you think, the first picture or the second picture, is associated with an underlying mass lesion? So first or second has a mass? Second. Good. So great. The second has a mass. And the reason why we know that is because the pattern of edema here spares the cortex. So this is vasogenic edema. As opposed to cytotoxic, this is a stroke because the edema goes all the way out to involve the gray matter. And essentially that's because you have cellular swelling, basically the cytotoxic, the cell is dying, so the NAK pump doesn't work, and so essentially the cell swells up, and the fluid that we see is basically a dying, swollen gray matter cells. So this involves both the gray and white matter, and you can see this kind of schematic of it cytotoxic being intracellular fluid accumulation, whereas vasogenic, which we see typically with tumor and abscess, especially metastatic disease, incites a ton of vasogenic edema, is leakage of fluid into the extracellular fluid space from the capillaries. And that is represented over here, where you see that the cells are kind of normal, but you just have increased extracellular space, and the gray matter is preserved in those cases. A caveat is, however, though, with encephalitis, rather than an abscess, sometimes you can have some gray matter involvement. So that's just one caveat to keep in mind. But going back to this case, here we see a lesion with classic vasogenic edema surrounding it. So what's the differential here in a 60-year-old? You know, what could this be? Just throw out anything. Yeah, so, you know, infection, so it could be an abscess. It's a ring-like lesion, right? So it could be an abscess. It could be a primary or metastatic tumor, right? So here, after contrast, we see a couple of more lesions. We see kind of nice peripheral enhancement. So now what do we think it is, most likely? Could still be. So metastatic disease becomes much more likely than a multifocal primary tumor, right? Although, you know, multifocal primary tumor can happen, but we're thinking metastatic disease most commonly. Abscesses, multifocal abscesses can happen, but you know, this one is kind of almost solid in appearance, and some of these have a very, very kind of thick nodular wall, and this was a metastatic disease. However, you know, abscesses would still be in the differential. So, you know, when you have multiple ring-enhancing lesions, your top two things by far are metastatic disease and abscess. And, you know, and of course, the clinical many times helps us, you know, suspect abscess. So, you know, metastatic disease in the brain always enhances. And that's because, you know, it's really something from outside the brain that is kind of not where it's supposed to be. So it always breaks down the blood-brain barrier. So it always enhances. You know, that being said, on MR, you definitely see some lesions that you don't see on CT just by the nature of CT and the certain limitations of CT. They're often multiple, although you know a single solitary MET is also not uncommon, and in the differential for a single intraaxial lesion as well. But you have to consider multiple abscesses, less commonly, as we mentioned, multifocal primary tumor. Demyelination and enhancing subacute ischemia are things that people don't commonly think of as ring-enhancing lesions, but they can enhance. They can ring enhance, and they're atypical presentations, but you know there are things that could be considered in this differential. So, you know, when we're dealing with an intraaxial lesion, even a solid intraaxial lesion, we still think of a solitary MET just because METs are so common. And then, you know, there are, you know, really a lot of brain tumors that are in the differential, but, you know, just to kind of pare it down to the top three things, I think is METs, glioma, and lymphoma. You know, if you kind of think of those, you'll really cover the majority of tumors that will occur in adults. Glioma, of course, is a very wide basket, and it covers a lot of different grades of tumors, you know, from low grade, nearly benign tumors to GBMs, grade 4 gliomas. Here, we'll just look at this case. This is without contrast, and we see a hypodense lesion here. So this is either a hypodense lesion or an area of edema. This is kind of expanding the splenium of the corpus callosum. So based on this alone, it's hard to really tell what it is, but we would think of a mass involving the corpus callosum or an edematous process. And here we have contrast. We see that there's peripheral enhancement, there's central necrosis, there is a mural nodule here, and there is a big nodule, and you can see on the non-contrast, you couldn't even tell that there was a lesion there. And so some lesions you really only see with contrast on CT. So what do we think this is? Any thoughts? So this is an ugly looking tumor. So this is a GBM. And we'll just go over some of the classic findings in GBMs. So GBMs have heterogeneous enhancement. They will always have some enhancing component, typically a thick nodular component, as opposed to an abscess, which has a smooth wall typically. So if you see really a solid nodular component like this, you're not thinking abscess. And then they typically have a necrotic cystic component, as opposed to something like meningioma or lymphoma that typically has relatively uniform enhancement. Corpus callosum is a classic location. You know, you guys have probably all heard of the term butterfly glioma, and that's that would be a good description of this here, where it basically crosses on both sides of the corpus callosum. So the surrounding hypodensity, which you see, is, you know, sometimes people just say it's edema, but really it's in glioma, it's a combination of non-enhancing tumor and edema. So in metastatic disease and abscess, you have frank vasogenic edema from leaky capillaries, but in gliomas in general, a lot of times you're looking at non-enhancing tumor and edema mixed together. So just something to keep in mind. Another example of GBM, so you know, here we have this, again, this vasogenic pattern of edema. You see some of this cortex preserved. We have hypodensity in the parenchyma. Then you have this kind of cystic appearing heterogeneous lesion. After contrast, you see that there's really irregular, ugly looking enhancement, some nodular areas. So this is another GBM on CT. So here's another case where we have a non-contrast CT just showing kind of vasogenic edema pattern. There's clearly some mass effect. There's midline shift. There's effacement of the sulci here. So we're worried about an underlying lesion. Maybe there's an underlying abscess. Maybe there's an underlying med or glioma. And here we give contrast and we see nothing, right? There's no enhancement here. So now what are we thinking? So, you know, it's not going to be an abscess. It's not going to be a met. But can we say that, okay, there's not tumor here, and, you know, maybe this is just, maybe, you know, should we reconsider that this is stroke? Well, you know, we still have preservation of the gray-white. It's still a vasogenic edema pattern. So, you know, we really can't exclude tumor, because this could easily be a non-enhancing infiltrative low-grade glioma. So, you know, high-grade gliomas like GBMs enhance, but low-grade gliomas can be just infiltrative and non-enhancing. So this is a low-grade glioma. And cerebritis could also look like this as well.
Do you have to get an MRI just to make the diagnosis, or
Well,
can you make that diagnosis based on that?
you know, you would get an MRI, but there's a lot you can basically see the findings here, but you would always get an MRI, you know, if the patient has a tumor, you know, essentially, just because that's just a standard of care. But there's a lot that you can get from the CT. And of course, there could be other findings on MR that don't show up. You know. So here, what are we looking at? So we have, again, you know, vasogenic edema pattern, right? So we have preservation of the cortex here. We have edema, certainly, all this hypodensity. And then we have this hyperdense area here. So is this a hemorrhage? Is this a hematoma? Could be, certainly could be an edema, parenchymal hematoma with surrounding edema. Or it could be a hemorrhagic mass. But after we give contrast, we can see that it diffusely enhances. So it enhances pretty homogeneously. So this is lymphoma. So CNS lymphoma, you know, the hallmark on CT is that it's hyperdense and bright on CT. And after giving contrast, it tends to enhance homogeneously. It's not cystic or necrotic like GBM or abscess. So here we can kind of very strongly consider the diagnosis of lymphoma if you see, particularly if it's centrally located in the periventricular regions. Lymphoma loves the paraventricular regions, and you know it's hyperdense based on its cellularity and its kind of nucleus to cytoplasmic content. There's some other lesions that are also classically dense, like in children, medulloblastoma and PNET. Meningiomas can be somewhat dense as well. That's partly due to the calcification. But you know, if you have an adult with a hyperdense parenchymal lesion, you can very strongly consider lymphoma. Usually they have solid enhancement, diffuse enhancement. However, in compromised patients, such as people with AIDS, they can actually have cystic ring enhancing lymphoma. So that's the one situation where lymphoma will not look like that. So here's a hyperdense lesion. Is this another lymphoma? It's just kind of to show you a pitfall. This is It's hard to tell here. This may be partly parenchymal and might be partly extra-axial. It kind of looks like it's centered in the suprasellar cistern, so maybe this is just a hematoma, but certainly you could consider, oh, it's just an exophytic dense lesion from the brain, but this was actually an aneurysm, so this is kind of a classic concentric lamellated appearance of an aneurysm on MRI. So just to be aware, if you have a hyperdense lesion that looks like it could be extra-axial, then of course you want to consider a hematoma, and in certain locations an aneurysm as well. So it's a different story if it's completely and clearly parenchymal. So the last thing we'll talk about with tumors is looking at or considering whether the tumors are in a location that could cause obstructive hydrocephalus. And these are even if a tumor is in this location and there's not hydrocephalus, you want to kind of really be very vigilant for it. If there's a tumor anywhere around the third ventricle, particularly cerebral aqueduct or fourth ventricle, because these are all areas where the whole ventricular system comes down to a small tube, and any kind of change in mass effect could cause kind of sudden hydrocephalus. That's really not the case around the lateral ventricles. If you have something pressing on the frontal horn or the temporal horn, that's really not going to obstruct downward flow of CSF, so that's not the case there. But the typical locations are the posterior fossa, any posterior fossa mass. This is juvenile polycytic astrocytoma, JPA, but any posterior fossa mass could cause this. And you can see here there's rastral hydrocephalus, the frontal and temporal horns are dilated, and this fluid around the ventricles is actually CSF being pushed out into the interstitium, and that tells you there's acute hydro. This is another kind of classic location of a mass to cause hydrocephalus. This is a patient with tuberous sclerosis, and they have this enhancing lesion right at the foramen of Monro. So the foramen of Monro is right here, where the lateral ventricle communicates with the third ventricle. And if you have a lesion there, it can cause obstruction and hydrocephalus, sometimes only affecting one side. But these are always at this location, these called sagas, and that can typically give you hydro as well. Of course, you can have non-neoplastic things also giving you hydrocephalus. This is a colloid cyst. So this is also something, if you see a small non-obstructing colloid cyst, you still want to monitor it and get a neurosurgical evaluation, because these can very quickly give you hydrocephalus. Okay, so let's take a look at this case. So what are we seeing here? We can see definitely in the right frontal lobe there is hypodensity, parenchymal hypodensity. And it looks like you can see some of the cortex here. There's so much mass effect and it's so expanded that it's a little hard to tell, but it looks like you have a strip of cortex here and here. So we're thinking this is probably vasogenic edema. It looks like there's an egg right here underlying, right? So it looks like there's a focal lesion. So, what could this be? This could be a MET, right? This could be a primary tumor. This could be an abscess. So let's give contrast, and this is how it looks. So, any guesses as to what this is? Let's throw out a guess.
With abscess.
Abscess. Yeah, it is an abscess. It is an abscess. And this was from a right frontal sinusitis. You can see really this black air over here in the left frontal sinus, and this right frontal sinus is opacified. So this patient had a frontal sinusitis that led to a cerebral abscess. So how do we know that this is an abscess? Well, a non-contrast is very tough. You'll see vasogenic edema pattern. You may see a focal mass lesion, but it's really similar to a MET or a primary tumor. But with contrast, you can definitely make the suggestion that you're dealing with an abscess rather than a tumor. So here, some of the things that we see are a smooth, thin wall, and particularly the inner margin. If you have kind of a long-standing abscess, the outer margin can start to become thick over time, but the inner margin here always stays smooth. Another classic finding is a little daughter cyst. You see this little thing over here? So essentially a budding appearance It's very, very suggestive of an abscess. Another finding is that the enhancement is typically thicker towards the cortex, and you can see this enhancement is brighter compared to here, and that's because the cerebral cortical blood flow is 4 times more than that of the white matter. So it's just, you know, the cortex is much more hyperemic, and that's why, and of course, the abscess is hyperemic, and it parasitizes more blood flow from the cortex, from the periphery of the mass. So here's just another example with MR, also showing a little daughter cyst, a little budding appearance, and I'd be remiss in telling you that if I didn't tell you that diffusion weighted imaging with MRI is really the way to go if you're suspecting abscess. You can definitely suspect it on CT and on contrast enhanced CT, and if the patient has a contraindication, then you can pretty strongly suggest that that's what you're dealing with. But diffusion, you'll see central bright signal here, and it's really very classic. Whereas opposed to with tumor, necrotic tumor, the central part will be dark, and then the peripheral cellular part will be bright. So it's kind of an inverse image on diffusion. So it's very interesting and very, very helpful in these cases. So another thing to just remember with infection is any extra-axial collections, be very suspicious for possible subdural empyemas. Subdural empyemas usually need to be drained, especially if they're sizable enough, pretty urgently. So the hallmark finding is enhancement, thick enhancement along the walls of the collection, as opposed to a kind of a sterile collection, which won't have that thick enhancement. So this was a child with TB meningitis, and he has infarcts in his basal ganglia. So why does he have infarcts there? So this is actually due to vasculitis from the perforating arteries, because TB meningitis typically gives you a thick basilar meningitis. So here you can see this example from an MR where you see very thick enhancement all along the basal cisterns and surrounding the pons and filling the suprasellar cistern. And this is a correlative autopsy specimen showing this kind of all this purulent material surrounding the brainstem. So these people get these patients get a vasculitis of the perforating arteries that go up into the basal ganglia, supply the thalamus, supply the lentiform nuclei, and can get infarcts in those areas. Just like people with vasculitis can get infarcts anywhere. So, but this typically tends to happen in the central gray nuclei. And the differential here would be something like a leptomeningeal carcinomatosis or a sarcoid as well. This was also a infant with TB meningitis that had hydrocephalus, and so sometimes on non-contrast CT, that's the only finding we see. And even on contrast enhanced, they may or may not have abnormal enhancement, so hydrocephalus may be the only thing that we see on CT. It's another case, a patient with HIV. You can see that there is parenchymal hypodensity here. It looks like there is some mass effect associated with it. There looks like there's narrowing of the third ventricle here. So you'd be worried about this person developing hydrocephalus. And so in an HIV patient, we're concerned for opportunistic infections. What else, possibly? You certainly get lymphoma as well. And if you remember, the lymphoma has a different appearance in the HIV patients. So this person, this is an MRI flare image. And you can see that there's edema and mass effect as we suspected on the CT, and then there's a ring-enhancing lesion here, and the differential for this would be toxo or lymphoma. And lymphoma can look just like this in immunocompromised patients. In an immunocompetent patient, they always look homogeneous and will not have this kind of necrotic appearance. But this turned out to be toxo. Just another thing you want to also be concerned about in basal ganglia infections in an immunocompromised patient, HIV, is of course cryptococcus also, and that typically is best seen on MR, not well seen on CT, because the hallmark there is actually enlargement of the perivascular spaces, which is kind of a subtle finding to see on CT. So, we talked about some of the complications of infection, like hydrocephalus, uncommonly infarct, but certainly can happen. But also you want to be concerned for sinus thrombosis. And here we have an example of non-contrast CT showing a nice sinus thrombosis here. You could think that this is a subdural hemorrhage if you just look very quickly, but this is really tracking right along the transverse sinus. So, and if you go up and down, you can see that this is will be a tube, not a sheet-like collection as you would see with a subdural hematoma. So here is a little less obvious example of mildly hyperdense sinus, but asymmetric from the other side, called a dense triangle sign. And then if you give contrast in the same patient, we can see that there's enhancement surrounding, but there's a filling defect. So this is a positive case for sinus thrombosis, something you always want to be very vigilant for in patients with infection, particularly mastoiditis. They tend to get sigmoid sinus thrombosis. And you can even make the diagnosis or suggest a diagnosis and then go forward with an MRV based on the non-con CT. Okay, so I also just want to mention that a calcification can be a really useful thing to look for on CT as well. Here we have a lesion here. It kind of looks like maybe this is a cystic necrotic lesion. Maybe there's some adjacent edema as well. But we also have some local calcifications. We have a calcification here, we have a calcification here, and this is actually kind of a target sign. So when you have the central dot here and the surrounding halo around it, this is a classic finding of cysticercosis. And the fact that we have other calcifications here tells us that this is most likely cysticercosis and some different stages here. This is a kind of an old healed stage, when you see calcification there. And this is the same patient earlier on where there was more active edema kind of throughout the brain. And there you can see little cysticercous lesions here on the previous MR. So, so it's very useful to look at calcifications. However, they're not always due to infection in the brain. You can certainly have vascular calcifications from an AVM or a cavernoma. And then there are certain tumors that are known for having calcifications. And the most classic are oligodendroglioma, ependymoma, and ganglioglioma. Mucinous adenocarcinoma metastases can also calcify. So there are just things to keep in mind. If it's really a focal lesion, then you can potentially have a tumor as well with calcification. Certain extra-axial calcifications also are typically have calcifications as well. And developmental lesions, in this case, this is an example of a dermoid. And here, not only do we see calcification, but we also see fat. And so this is one of those rare cases where we can make a very specific benign diagnosis just based on the CT. This person had a ruptured dermoid, and you can see this little locules of fat all through the sylvian fissure, and they can get a chemical meningitis from the rupture of the dermoid. But we can say that, okay, this is a calcified fatty mass, so this is going to be a developmental lesion. This is not a tumor that's going to progress, something to necessarily worry about. So this is just, I think, toward the end of my talk. So this is a really interesting case I'll end up with. This patient presented to the ER, and this was his CT. So what's going on here? In the first, we see a chunky calcification here. In the next image, a few slices up, we see what looks like, what kind of edema here? This is cytotoxic edema, good. And this is going all the way out to the cortex. It looks somewhat wedge-shaped. So this person had an acute infarct. They came to the ER with an acute infarct. And this is confirmed on MRI. We have this diffusion, bright acute infarct. So, what was the etiology of this patient's infarct? So what do we think? Well, most commonly it's thrombotic, and pretty commonly it's embolic also, right? So vasospasm you see in the setting of subarachnoid hemorrhage typically, so it's not going to be that. Dissection, it certainly could happen, but there's nothing to really suggest that. But this is a really interesting case of an infection eventually leading to an infarct. And this was a patient 5 years earlier. And so they had this big cystic lesion, and you can see this kind of enhancement here. This was a racemose variant of neurocysticercosis. So, this basically involves the basilar cisterns. And so this was all this inflammatory enhancement in the basilar cisterns, and the lesion itself surrounded the MCA vessels in the sylvian fissure. So, as this lesion kind of shrunk down and calcified and got dystrophic calcification surrounding the MCA, it eventually occluded the MCA, and then 5 years later they had an infarct. So pretty wild case. So just to kind of review, of course, you guys are not going to be diagnosing brain tumors, in the middle of the night, but I think it's great to just have an approach to looking at CTs, and I think that just deciding whether a lesion is intraaxial versus extraaxial, you can come up with a very reasonable kind of top 3 differential of what you could be looking at. There are things you want to always evaluate, like are we looking at a stroke, or is this vasogenic edema, which is more likely associated with tumor or abscess? And of course, are there any urgent secondary findings or impending findings, like impending herniation or hydrocephalus? And then you can get to things that we talked about, like if there's any focal lesion visible within the edema, can we characterize it with CT? And there's usually a lot we can characterize, even with CT, before we get the MR. Okay? All right, that's it for me. Thank you very much for your attention.